morning, everybody. Obviously, it's not very easy task to start to work early morning in Saturday. I would like to present an historical review of the Circle of Willis. Of course, we have to start by the question, who is Thomas Willis? He was born in 1629. He is an English physician, scientist, and experimentalist, and a pioneer in research. He was professor of natural philosophy at Oxford, and most of his career is in Oxford. He's a founding member of the Royal Society of London for Improving Natural Knowledge, also known as the Royal Society. This is one of the first, maybe even the first of society of this type that has the main objective to give advice to the government how to manage and how to develop the science as a whole. And he was one of the royal physicians of Charles I of England. He published a lot of landmark books, but today we shall speak more about his inputs regarding anatomy, regarding neurology, and in fact, he was the first physician to use the term neurology. He was also among the first to present the notion of a circulating hormone from the pituitary gland. He was the first to make a complete revision of the cranial nerves, to rename and describe them in the way that we know today. We are using his classification. He was the first to give the modern description of the blood supply, not only of the brain, but also of the spinal cord. He described different anatomical structures that are important for the clinical practice. And he was the first to describe also the medullary pyramids, as he named them, the anterior commissure, and the cerebellar peduncle, and other important anatomical structures. But today we shall speak more about the circle that is named, as we know, the Circle of Willis. In 1664, he published a book named Anatomy of the Brain with a description of the nerves and their function. I will make a citation. There may be a manifold way for the blood about to go into diverse regions of the brain, so that if by chance one or two should be stopped, there might easily be found another passage instead of them. So this is the first description, not only of the Circle of Willis, but the first attempt to explain what is the function of the circle, of this circle. But what was the historical context where all these investigations have been made? There are two important points that have to be mentioned. First, this was the end of the English Civil War, that was from 1642 to 1651, and the royalists were fighting against the parliamentarian. As any civil war, this was disastrous for the whole country. On the other hand, in this period, there was a recurrence of the plague. As we know, the plague has killed more than 30% of the population of Europe about a century before the time that we are talking about. But there are several recurrences, and the last one was exactly in 1665 and 1666, and it was known as the Great Plague of London. So as you can imagine, these are not the perfect conditions to perform scientific research and scientific work. But maybe the most important obstacle for Willis and all the scientists of this period was the Galenic doctrine in medicine and anatomy. Galen, also known as Galen of Pergamon, was born in 129. He was a prominent Greek physician, surgeon, and philosopher. He acquired his initial experience as surgeon by treating the gladiators. As you can imagine, this is a very good possibility to acquire a good experience for a very short period of time. He made fundamental concepts in medicine and philosophy, and was one of the most prominent scientists of his time. His work was so fundamental and so important that in fact he influenced Western medical science for more than 1,300 years. Not 13, not 130, but 1,300 years. So, as you may imagine, this is a very strong tradition that was not easy to fight, because what was the problem with the concept of Galen? The problem was that a part of his notion for our body were wrong from our contemporary point of view. I will give you some of them. Galen told that the cardiovascular system consists of two completely separate one-way systems of distribution. One of them was the venous system, and the venous blood was generated in the liver. The other, the completely separate arterial blood, was originating in the heart, and they are going in a forth and back way from the heart in an ebb and flow motion. So every scientist, every physician from this 1,300 years, if you ask any one of them, anyone would told you that this is the way that our body was functioning. This is the way that our heart is functioning. You can imagine that this was the concept that was completely accepted by all of the scientists during this long period. The thing has started to change in 1213 by an Arab physician, Ibn al-Nafis, who was born in Damascus and published a book, Commentary on Anatomy in Avicenna's Canon. In this book, he described the following: the blood from the right chamber must flow through the vena arteriosa, actually known as the pulmonary artery, to the lung, spread to its substance, pass through the arteria venosa, actually known as pulmonary vein, and reach the left chamber of the heart. In fact, this was the first description of the pulmonary circulation. This was one of the first breakthrough to the concept of Galen. Later, we have the anatomical drawings of Leonardo that are giving also a new concept of how our body is functioning. And the work of Andreas Vesalius, The Structure of Human Body, that was so important, so different from all the actual concepts, that in fact Andreas Vesalius has become the father of the contemporary anatomy. It's very important to mention William Harvey. He was the first physician that, we may say, made a revolution in the way that we are understanding how our our body is functioning and how our system, cardiovascular system, is functioning. In fact, he was the first to completely change the concepts and to tell that the heart works as a pump, that the arterial and the blood and the venous blood are circulating in a circular way. So the heart, what we know actually as a notion, that our heart works as a pump, that the blood does not drift in the body in any sort of random ebb and flow, but is pumped endlessly around a very precise circuit. This concept was so different and so important that we may compare it with the discovery of the DNA. So, the circle of Willis before Willis was mentioned several times by different investigators. We have to mention Gabriel Fallopius, who described part of this circle, Giulio Cesario, that illustrated the circle of Willis, but not completely. Jan Wessling, that also made investigation regarding this circle, and Jan Weffer, that in his book published in 1658, clearly described in details the whole circle, but failed to make a good quality illustration of this finding. So what were the key points of the success of Willis for his discovery? On the first place, this was a dissection method and the dissection skills. Previous anatomists approached the brain by dissecting it in situ. They open the cranial vault and make a dissection in situ. And as you can imagine, these do not give you a good access to the basal anatomical structures. Willis and a group of his co-workers tried a completely different way. They removed the brain as a whole from the cranial cavity and dissected it apart. So this, of course, gives them an important advantage. The second key point are the illustrating skills. All the marvelous illustration in his book was made by Christopher Wren. By the way, Christopher Wren is one of the very important figures in the architecture of England, and in fact, he is the most highly acclaimed English architect in the history. He is accorded to be responsible for the rebuilding of 52 churches in the city of London, amongst which the St. Paul's Cathedral. So he was a very prominent architect, and but before becoming such a prominent architect, he worked with Willis as a collaborator and made wonderful illustration of his anatomical studies. And the third important key point for the success of Willis is the discovery of the intravenous injection. In 1650, Christopher Wren, that I just mentioned, with Richard Lower, invented the intravenous injection. You can imagine how important was this for the whole medicine. This was a completely new and different concept. For us, intravenous injection is something that we see every day, but for the time that we are discussing, this was a small revolution. So they discovered the intravenous infusion. By the way, Richard Lower will later made the first blood transfusion from a sheep to a dog initially, after that from a sheep to a man, by the way, with good initial results. So this method of infusion was used for the injection of ink in the venous system of a dog, and this gives a completely new way of, a completely new view of the communication between the blood vessels that was extremely important. Finally, this method was similar of the principle that will predate the radiological angiography. You can imagine how important is that. So, if you have to reiterate, Thomas Willis was the first to describe the circle and to present the first realistic, high-quality illustration of it. What is even probably more important is that he was the first to recognize the physiological significance and importance of the circle in the maintenance of the collateral flow of the brain. He never thought that this circle is his circle. It's not then only, it's about 100 years later that Albertus von Haller in his Bibliotheca Anatomica was first to attach the name of Willis to this circle. Subsequently, circle of Willis has gained a popularity and became a commonly used eponymous name. Regarding the study of the circle of Willis, the next step was the cerebral angiography. The Portuguese neurologist Antonio Egas Moniz was one of the founder of the modern psychoneurosurgery. He introduced in the neurosurgical practice the leucotomy, also known as lobotomy in some situations. For this invention, he received a Nobel Prize in 1949. This was quite contradictory because his great invention, in fact, was the cerebral angiography. You can imagine the importance of the cerebral angiography for studying the brain in a period of time when the only way to study the brain was the pneumoencephalography. This was the only method for acquiring additional information about the brain, image information. So he developed the cerebral angiography, and this gave completely new view of the circle of Willis. Next step in the study of the circle of Willis was the development of the neuroembryology. We have to mention the names of Raymond y Cajal, the work of Hiss and Kupfer, and also of Streeter. But probably the most important regarding the circle of Willis work was made by Dorcas Paget. She published in 1945 two landmark papers. The first one was the development of the human cranial arteries in the human embryo, and the second was the circle of Willis, its embryology and anatomy. By this study, we acquired a new knowledge about the development of the circle of Willis. And here you can find on this scheme a human embryo in different stages of development. I will not go in details, but as you may see, at day 44, we already have a well-developed circle of Willis. So this means in early stages of development. The next step of investigation of the circle of Willis and the brain as a whole was made by Professor Yaşargil. He was from Turkish origin, but most of his study was performed in Switzerland. In fact, he was the father of the modern microneurosurgery. He gave a new concept for gaining access to different structures of the brain by the arachnoid cisterns, and he made a very important microanatomical study. And in fact, he is the father of the contemporary microneurosurgery. The whole Neurosurgical Society agreed that he was chosen for the most important neurosurgeon for the second half of the 20th century. Here I will show you some examples of microanatomical studies that we performed in our hospital and that are dedicated to the better knowledge of details of the anatomy of the circle of Willis and mainly of the posterior part of the circle of Willis. We used a method with red-colored latex that was injected in the vessels of the brain, and we made a dissection, microdissection, under optical magnification of 6 to 40 times. So we use, this is the circle of Willis in a standard specimen of our study. We used also standard nomenclature, anterior perforating branches and posterior for this that emerge from the P1 segment. We studied also the zone of penetration of all the perforating branches. We divided all the group in three, depending on the communicating posterior artery. The normal situation, the adult type, was when the communicate posterior artery was more than 1 millimeter in diameter and is smaller than the P1 segment of the posterior cerebral artery. We have hypoplasty when we have a smaller communicating posterior artery than 1 millimeter, and a fetal type when the communicating posterior artery is larger than the P1 segment. We made a lot of studies in details. Here you can find the bilateral hypoplastic communicating posterior arteries. This is an example for a fetal type. You can see that the diameter of the posterior communicating artery is much larger than the diameter of the P1 segment of the posterior cerebral artery. This is an example of bilateral fetal type, as you can see on one side, and on the other side, the posterior communicating artery have larger diameter than the P1 segment of the posterior cerebral artery. These are different anatomical variations, and I don't want to go in details with the numbers, but what is important that for these three types of posterior communicating artery, adult, hypoplastic, and fetal type, there was a very similar number of perforating branches, and the pattern of distribution of these branches was also similar for these three groups. So as you may see, even in a hypoplastic posterior communicating artery, we have a large number of perforating branches that are emerging. So our conclusion was the hypoplastic posterior communicating artery tend to be slightly longer and with a distinct reduction of the diameter from the anterior to the posterior third than the adult type of posterior communicating artery. So the main importance of this conclusion was that during surgery you can make a section of the posterior communicating artery if you preserve the perforating vessels. But even in cases of hypoplastic posterior communicating artery, you have to be very careful because obviously, despite the hypoplasty, functionally this artery is important. This study was published in Acta Neurochirurgica about more than 10 years ago. What is strange that during that period, this conclusion was important mainly when dealing with, when operating aneurysm of the basilar tip. Actually, this surgery is not performed very frequently, so this conclusion is important only in situation in neuro-oncology when we try to gain wider exposure of the cranial base and we have to section this artery. We made also a study of the premammillary artery. I don't want to go in details, but this is the largest and most important perforating branches emerging from the posterior communicating artery. Usually there are one premammillary artery, but in about 25% there are two or even three. The premammillary artery is emerging mainly in the middle third of the posterior communicating artery, but there are some interesting anatomical variations when you can find it emerging from the internal carotid artery or from the P2 segment of the posterior cerebral artery. As you can see, the reduction of the diameter of the posterior communicating artery usually appear after the emergence of this branch, this important branch, this important perforating vessel. This is another example. With the asterisk, you can see the premammillary artery. Another example, this is the premammillary artery. There are some cases where the posterior communicating artery, we may say that exists just to give this branch, that is the premammillary artery. As you may see, the continuity of the posterior communicating artery is a very thin branch, almost inexisting branch. So this is an interesting variation that has not been described in the literature until this study. This is an interesting case of emergence of the premammillary artery from the internal carotid artery, and in this situation we may find the emergence of the premammillary artery from the P2 segment of the posterior cerebral artery. Another example of the same anatomical variation. This is an endoscopic view of the posterior communicating artery and the premammillary artery. In fact, this is another way to study the brain with neuroendoscopy, because this gives you the possibility to have a look around the corner and to see structures that you cannot see with the operative microscope. So the conclusions for this was published some years ago, also in Acta Neurochirurgica. We made study of the P1 segment that you may see. We learned how is the branching pattern of all the perforators, and the important conclusions that we have made from this study is that the P1 segment, even when it's hypoplastic, may give an important perforating, may give beginning of the important perforating branches that have to be spared during surgery or endovascular procedure, and that usually the first perforators emerge about 1 millimeter distal to the bifurcation of the basilar artery. So these are different anatomical variations and infundibular dilatations of the unilateral or bilateral of the posterior communicating artery that are also interesting as a part of the anatomical variation of the circle of Willis. So, regarding our knowledge about the circle of Willis, next step has been made with the CT and MRI angiography, because they give us the possibility to study this, the circulation with non-invasive methods. And of course, we have to mention the mathematical modeling that is quite complex for me to explain it. But this exists as a method for investigating the circulation through the circle of Willis. Last but not least, we have to tell that actually in the era of neuroendovascular procedure, the circle of Willis become more and more important from a different point of view as a collateral access for endovascular procedures. There are a lot of recent publications that are describing the use of different approaches by the collateral circulation to different parts of the brain. And I think that this is important as a contemporary view on this circle. So this was a long history starting with Galen by passing to William Harvey and discovery how our cardiovascular system work, by Thomas Willis, Neuro Embryology, Egas Monitz, and actually we may say that for the circle of Willis we know first that this is the most common place for aneurysmal formation. This is an important collateral flow for the brain. The circle of Willis is important in the reduction of the hemodynamic stress of the arteries of the brain. The perforating vessels of the circle of Willis have to be preserved during surgery, and this is very important for the good result. Some part of the circle of Willis may be sacrificed during surgery if the collateral flow and the perforating vessels are preserved. The circle of Willis can be an important alternative for access during endovascular procedure, and the mathematical modeling and the non-invasive imaging studies will be the basis for our future understanding of the circle of Willis. What we're going to discover, if we're going to discover some new, interesting, even revolutionary thing of the circle of Willis, is a question that we'll have the answer in the future. But actually, we have had a long way in our understanding, and I think that this is one of the important discoveries that we may be proud of. Thank you for your attention.
Are there any questions? Thank you, Doctor, for your lecture. I have a question. Did you say that when you have a PCOM hypoplastic artery, the perforated feeders are located and predominantly in the yes, in the when you did you find any variation in normal or fetal PCOM referred to perforated artery?
Yes. We have three groups, but in fact our study demonstrated that the variation between the adult and the hypoplastic type are not very important. So we have to treat the hypoplastic artery as a normal adult type artery because it has the same number of perforating branches and almost the same anatomical characteristics. Regarding the fetal type, this is a quite different situation. The fetal type even have less perforating branches than we may expect, but as we know, the function of the fetal type is to ensure the circulation for the posterior part of the brain and to ensure blood flow for the P2 segment and the distal flow. So for the adult and hypoplastic type of posterior communicating artery, we found that first there is a reduction of the diameter from the anterior to the posterior part, and second that the largest number of perforating branches is situated in the anterior and the middle part. So the conclusion was that if we have to perform a section in any situation, maybe the last third is the most appropriated part where the risk of damaging vessels, perforating vessels, is the less. So this was the conclusion, and this is a practice. This is not the easy. It's much more easier to cut it in the beginning, but if we have the possibility, it will be wiser and more safe for our patient to do this in the distal part.
Thank you, Doctor. Yes.
Origin of the The origin of perforators from the P1 segment also depends on the very nice study done by, published by Pierre Lachonias, that whether it is a caudal fusion or a cranial fusion, because the formation of the basilar artery is through the unification of two dorsal arches. So depending on whether it's a caudal fusion or cranial fusion, which can be symmetrical or asymmetrical, actually has a very good orientation for the origin of the P1 perforators. If there is an asymmetrical, what you call fusion of the particular basilar formation, then the dominantly the P1 perforators or the thalamic perforators, they originate from the vessel which is cranial, right? So this is a very important, I think, piece of information which we have from embryological variations.
Well, what is important that there is a reciprocal relationship between the perforating vessels of the posterior communicating artery and the P1 segment. So usually when one is more developed, the other one is not so well developed. But also in P1 segment, we have to mention that the hypoplastic P1 segment does not mean a hypofunctional P1 segment. You may have a large number of perforating vessels. So regarding the discussion yesterday for sacrificing some part and some arteries, I have that this is very important. Not always the hypoplasty, the visual hypoplasty, means a functional hypoplasty. So you may have an emergence of very important perforating branches, and you may have a devastating results if you do not spare them. Thank you.
We're going to continue with the lecture of Dr. Stefan Hudak. Stefan, the topic is arterial fenestration, a common phenomenon unexplained in subarachnoid hemorrhage.
Good morning. Today I would like to talk about arterial fenestration and idiopathic subarachnoid hemorrhage. Our aim was to assess the frequency and location of any fenestration of intracranial arteries and to examine their potential involvement in the development of idiopathic subarachnoid hemorrhage. In a prospective consequence series of 287 patients admitted with acute subarachnoid hemorrhage or for the management of an incidental aneurysm for 2009 and 2012, we employed 3D rotational angiography to identify the bleeding source and to assess the frequency and location of any fenestration of intracranial arteries. Since in 2013, all other idiopathic subarachnoid hemorrhage cases were investigated with this method as well. In the significant percentage of patients suffering from acute subarachnoid hemorrhage, the source of the bleeding remained idiopathic subarachnoid hemorrhage. Fenestration of the intracranial arteries are variants resulting from the incomplete fusion of vessel during development. Their clinical significance is unknown yet. Fenestration generally hidden on routine 2D digital subtraction angiography are more easily visualized by means of 3D rotation angiography, as 3D rotation angiography permits the improved visualization of the cerebral vessel from any desired angle. In 29% of the patient, arterial fenestration were found. From the 174 patients suffered from the CT proven subarachnoid bleeding, 153 had aneurysm, and in 21 patients, the source of the bleeding could not be found. From the 153 patients with an aneurysm, 23% had an arterial fenestration. From the 21 patients without an identifiable source of bleeding, 20 patients had an arterial fenestration. In the only patient without fenestration had trauma may have been the cause of the hemorrhage. Nowadays, one group from Netherlands demonstrated a very similar fenestration rate of intracranial arteries. In 47% of the patients with both fenestration and aneurysm, the fenestration was topically related to the aneurysm. In 9 patients, dilatation of the fenestration possibly and aneurysm in development was seen. In 53% of the patients with both fenestration and aneurysm, the fenestration had a different location. In 20 patients, the fenestration was present without an aneurysm. Proportion of the site of arterial fenestration, 56% it's arterial communicated artery fenestration, 15 it's basilar artery, 11 it's anterior cerebral artery. So fenestration unrelated to the aneurysm. 53-year-old female with enruptured ophthalmic aneurysm, no abnormality can be seen in standard position. Angiogram after coil occlusion of aneurysm. But non-standard projection reveals 6 fenestration of the anterior communicated artery. The next, except 2 aneurysms, there are on another abnormalities on standard angiogram. After occlusion all aneurysm, we do non-standard projection, nearly axial projection in the some patients show 3 fenestration of anterior communicated artery. Fenestration topically related to the aneurysm. 48-year-old female with subarachnoid hemorrhage, fenestration on proximal basilar artery and giant fenestrated aneurysm of the basilar bifurcation. 81-year patient with ruptured aneurysm on the anterior communicated artery, associated with 2 fenestration of the same location. Is same 3D reconstruction and after operation. 55-year female with large ophthalmic aneurysm on the right side associated with aneurysmal fenestration of the internal carotid artery. Multiplex 4 aneurysm with idiopathic anterior cerebral artery. And you can see pre- and post-operative picture, and 3D reconstructors show a fenestration next of the aneurysm on the anterior communicated artery. 41-year-old male MRI angiography was performed in the son of the previous patient as part of the aneurysm study. A silent aneurysm was suggested, however, no abnormalities were seen on the DSA of standard position. And 3D reconstruction and non-standard protection show arterial communicated artery fenestration. 61-year-old patient with interhemispheric hemorrhage, carotid and vertebral angiography. The vertebral angiography show excellent collateral flow through the posterior communicated artery. And high resolution subtraction angiography in appropriate projection and 3D reconstruction show aneurysm associated with 2 fenestration. There is direct connection between the aneurysm and fenestration. It's after occlusion. Very interesting cases with 34-year female patient with subarachnoid hemorrhage, anastomosis between posterior cerebral artery and aneurysmal sac. It's 3D reconstruction in different views and after occlusion. Very interesting on 3D reconstruction arterial anastomosis fenestration between the internal carotid and posterior communicated artery. The next group is fenestration development of aneurysm from the fenestration. You can see 56-year-old patient with right middle cerebral artery aneurysm, pre- and post-operative imaging. 3D angiogram showed hidden fenestration, which is directly associated with the aneurysm. A second nascent aneurysm is visible on the opposite side of the arterial anastomosis. Very interesting case, a 27-year-old female patient suffered subarachnoid hemorrhage. The angiogram showed a dorsally projecting aneurysm associated with fenestration of basilar artery. On the ventral side, on the fenestration, a small evagination was visible. Control angiography 6 months later show an aneurysm and the site of the former evagination and evidence for the development of new aneurysm from fenestration. Postoperative angiogram shows the disconnection of the branch of the fenestration, which was thought of be the origin of the aneurysm. And last is fenestration in subarachnoid hemorrhage without identifiable source of bleeding. Proportion of patient with or without artery fenestration on cerebral angiogram. You can see 23% rupture aneurysm with 24 unruptured aneurysm and idiopathic subarachnoid hemorrhage 95%. Signs of 2013 and another 16 cases of idiopathic subarachnoid hemorrhage were admitted, and in all of them on the anterior fenestration was found. In the idiopathic subarachnoid hemorrhage cases, the fenestration was found in the region of the anterior communicated artery in 25%, on the basilar artery or vertebral artery in 10 patients, and the middle cerebral artery in 3 patients. 2 patients had fenestration in 2 localizations. Perimesencephalic hemorrhage in an idiopathic subarachnoid hemorrhage patient with a clot reaching the arterial communicated artery region, where anterior fenestration was revealed. In this picture, no abnormalities at first view. But in non-standard projection, high-resolution angiography and 3D reconstruction reversed 2 anterior communicated artery fenestration. They were the only detected vascular anomalies. Perimesencephalic hemorrhage in an idiopathic subarachnoid hemorrhage patient with a localized clot in the region of the left proximal middle cerebral artery, where a rare middle cerebral artery fenestration was found. We don't see abnormalities and non-standard projection. You can see middle cerebral artery fenestration and hemorrhage. It's same localization. 51-year-old male patient with subarachnoid hemorrhage, no abnormalities were found on standard projection. And this not prepontine subarachnoid hemorrhage is very big, massive subarachnoid hemorrhage. Non-standard projections show 2 fenestration of the anterior communicated artery, the only possible source of the bleeding. The next patient, it's same massive subarachnoid hemorrhage, and you can see fenestration. The next, you can see fenestration. Conclusion, arterial fenestration was detected in more than 20% of ruptured cerebral aneurysm, in contrast with nearly 100% of patients with idiopathic subarachnoid hemorrhage. As fenestration is a developmental defect, a structural wall weakness, making the vessel prone to rupture. Its incidence of the nearly 100% is strongly suggestive on the close connection with idiopathic subarachnoid hemorrhage. The presented data indicate that arterial fenestration are likely candidates as the mysterious source of the idiopathic subarachnoid hemorrhage. Aneurysm may develop from the arterial fenestration either through their slow dilatation or during rupture or dissection of the fenestration. The fenestration is a vascular anomaly, never normal anatomical variant. In the cases of subarachnoid hemorrhage without an identifiable source of bleeding, do look for hidden fenestration. Thank you.
Thank you very much. We have time for one question, yes?
Fenestrations. For example, with the unsecured aneurysm, you would expect to have recurrent subarachnoid hemorrhage, right? So in cases where there is no aneurysm but only fenestrations, which are obviously not secured, do they automatically destroy themselves? Is there an increased risk of recurrent bleeds or not? Because in our experiences, we have the same experience that, you do a repeat scan six weeks later, 8 weeks later, and you don't find anything. You don't find an aneurysm in those idiopathic ones.
So this my experience in treatment of aneurysm, and we look at fenestration, and I think later all clinic possible look possibility of fenestration, and I think this is pathology, but I think fenestration is pathological artery. And interesting of localization and fenestration, very same, it's absolutely same. And we see many fenestration with aneurysm. It's only small group of patients. Rebleeding. Now we have very small experience. I don't see rebleeding in all patients, but it's only 36 patient group. My clinic is not very big clinic, and it's possible later. So I don't have rebleeding in fenestration.
Thank you very much.
Thank you.
We're going to go now to the AVM and the AVF devices. And for that, we're going to invite Professor Shakir Hussain to come up to the stage. He's going to talk about targeted goal of partial embolization in AVMs using NBCA.
So, good morning, ladies and gentlemen. I think the topic of AVM is relatively more, I would say, time-consuming in the sense that aneurysm remains a more glorious way of working in neurointervention. But AVM is a complex disease, and so AVM remains as a complex disease, and it poses several challenges in the management even today with the advent of better understanding of the disease by several methods that we have to understand. Because most of the knowledge base that we have on AVM is from the neurosurgical side and from the pathological specimens. But with the advent of neuroimaging and their evaluation on various sequences of MR imaging particularly, and microcatheter injection of these AVM nidus has given a different and better understanding of this vascular malformation and has helped us in determining and eliminating them from the circulation to prevent the future risk of bleeding and its morbidity and mortality linked to it. In spite of these developments, the complete obliteration rate of AVMs using a single modality, which could be either microsurgical excision or AVM embolization or a gamma knife surgery, has been limited. However, careful selection of combination of methods improve the obliteration rate of AVM, but at an extra risk and a cost to the patient. In some clinical situation, patient may be benefited by partial targeted embolization. And here comes the role, because as compared to the risk of bleeding in aneurysm, the AVM remains as a benign disease. And in an unruptured aneurysm, the risk of bleeding in a patient is less than 1% per year. However, the risk of rebleeding in a ruptured AVM is larger. It ranges between 2 to 4%. In some clinical situation, a patient may be benefited with partial targeted embolization, particularly if you encounter or you find that there are weak area of angioarchitecture of the AVM which can be handled, or depending on the symptom of the patient, if those flow condition or hemodynamics can be modified, these patients can be benefited. Now, as we deal with any other disease, the final goal of the treatment by any method remains based on the risk-benefit analysis of a particular modality over the natural history of this disease. So the most important thing in the understanding is the high-risk group of patients of brain AVM, and we know today from the angioarchitecture analysis of the various AVM niduses that presence of the intranidal aneurysms, venous ectasia, venous stenosis, single draining vein, and particularly if you have a subependymal drainage system of these niduses, particularly in deep location of AVMs, and arterial and angiopathic changes makes these AVM niduses more vulnerable and high risk. Even if they are unruptured, they pose a higher risk as compared to the global risk of all kind of AVM which is considered the more benign. Now, it is important to see even from the gamma knife treatment point of view, which is a relatively less invasive method and more safe as compared to any other invasive method, but it also imposes its long-term complication in the form of post-radiation effects. It has been observed that angioarchitecture is again of paramount importance, and it has been seen that if, apart from the size of the niduses, which is a separate matter of discussion, if you have a high flow AVM or fistulous form of the AVM, they are relatively resistant to gamma knife treatment. The commonest clinical presentation that we see are in the form of intracerebral hemorrhage, which is seen in about half of the cases, and seizure is another most common manifestation, which is seen in 30% of the cases. Headache associated with hemorrhage or without hemorrhage is seen in about another 10 to 15% of the cases. Some people have what you call a progressive focal neurological deficit, particularly in high flow, large AVMs, where you have a steal phenomena and sump effect, and underlying the parenchyma getting hypoxic may manifest in the form of progressive neurological deficits. And they may be associated as an incidental finding for some other reason. If you perform an imaging, and you can find in about less than 10% of the cases as a coincidence. So the natural history understanding is very important. AVMs are a dynamic disease. It is inborn error of angiogenesis, but as there is a maturity of the arterial and the venous system happens in the life, there is a constant change in these AVMs. So it cannot be, a detection of an AVM cannot be considered as a static disease or a disease at a given point of time what it is, but it changes with the time and with the changing hemodynamic situation. Enlargement of the AVM is seen in young individual, especially in childhood. And in many situations, particularly in children, you may have a spontaneous complete regression of AVM following a single episode of minor bleed. That has also been understood and well documented. So it is important to look at the natural history, and one of the best, I think, the paper that I would recommend if there are fellows and residents who want to look at the Ondara study, which is the best defines the best natural history of these AVMs. And in the present time of our technological advancement, busy practices by means of any use of the technology, I think these natural history understanding are becoming more poor and poor. And as we saw yesterday also in the discussion, that when we talk about these large fusiform dolichoectatic vessels, or so-called fusiform giant aneurysms, we do not know the natural history. So it remains actually unclear whether we are intervening in this situation is clinically correct or not. So the annual bleeding rate in an AVM is about 4% per year following a rupture. As I said, and in an unruptured situation, it is about 1%. And the annual rate of mortality from the rupture is pretty low. So unlike the aneurysm rupture, which poses very high mortality and morbidity, the AVM is considered as a benign disease. And that is why it is in the management, it is not that aggressive and that serious issue, and it is more considered to be more a planned procedures and a careful decision. So the common goal for all people who are dealing with this problem is the AVM nidus. So how we define the AVM nidus? If you look at into the literature, the pathological diagnosis, the definition is different, but we commonly understand from all information from all method is that it is the area of the AVM which is interposed between the arterial segment which supplies this AVM and the exiting vein. So this is usually a dysmorphic area of the angiogenesis. So in the management of AVM, the most important thing is observation and follow-up of the symptomatic with the symptomatic treatment. One can consider microsurgical removal, radiosurgery, or embolization, and this in various combination, again depending upon several factors, right from the age of the patient to the presentation to the type of the AVM and the expertise which is available in a particular environment to deal with this situation. So the goal of the treatment that we have common in the management of AVM is the primary goal is to prevent the bleed in a high-risk AVM and to prevent the recurrence of the bleed in a previously ruptured AVM. And the other goals which may be in the form of in a clinical setting which we commonly encounter are to improve and stabilize neurological deficits, particularly progressive neurological deficit syndrome, to treat intractable seizures sometimes, and to reduce the severity and frequency of the headaches, particularly in large, extensive, high-flow AVMs. So which are the factors which influences decision makings are estimated natural history, anticipated risk of various modalities, as I said, expertise available, general condition of the patient, and so on and so forth. Look at this situation. This patient had an intracerebral hemorrhage. He presented with headache and mild visual symptom, which was in the form of, on examination, field defect. And when you perform an angiography, you find that there are several classifications which are available in the literature. But from the endovascular point of view, we follow the Zurich philosophy and the Zurich school of classification, which encompasses a broad category, the sulcal type of AVM and a gyral type of AVM. The sulcal type of AVM means that there are extra axial, they are located into the sulcal space. So they are good AVMs without affecting the parenchyma to be removed surgically or by endovascular means. So this is a typical example of a sulcal type of AVM which has a supply from the calcarine artery. The goal remains that the microcatheterization to the nidus. Any deposition, whether you deal with surgically, as yesterday Dr. Harnesian was mentioning that when you deal with these AVMs surgically or by any other method, there should be a very clear defined goal to deal with it, and it should not be a casual exercise to approach that let us see what we can do in this particular case. So your goal should be defined beforehand, and all targeted area of embolization should be performed. So once you have an intranidal deposition of the whatever embolic material that you perform, you can eliminate this AVM from the circulation completely.
So what are the objectives that we have to embolize as a patient for the definitive cure? That means remove them from the angiogram. Embolization as a precursor to the defined operative resection. Sometimes it is difficult to embolize them, but if you can combine these two methods, you can do a job for the neurosurgeon by dealing with some of the vessels which are difficult for them to access, particularly the deep perforating vessels. If you can embolize those areas, I think the surgeon will be able to deal with more efficiently and a faster way. Embolization as a precursor to radiosurgery to reduce the size of the AVM and make it more accessible and effective for radiotherapy. Embolization as a palliative measure for the progressive debilitating symptoms. We'll see some of the example of these cases one by one. So let us look at what are the tools that we use in endovascular embolization. There are various embolic agents, but I think one of the first and the foremost is the NBCA, which I think holds even today one of the most promising agent as far as we as interventionists are concerned. One of the most important factors for the use of the NBCA is that it's a very cost effective. And yes, it has its own what you call negative side because it polymerizes very fast. So you require to learn the technique of use of this agent. And once you learn that, I think it's a very, very easy agent to use and safe agent to use, I would say. But anyway, that is not important. What is important is that any agent that you use, which you are comfortable with, the goal remains the deposition of the embolic agent right into the nidus and without compromising the arterial territory to prevent underlying ischemia to the brain and morbidity linked to that. So angioarchitecture is very important, understanding by the microcatheterization and to understand which compartment of the AVM has the weak angioarchitecture, which would be the goal of the first embolization or sometimes the only embolization that you perform as a palliative embolization or targeted embolization in these cases. This is an example of a microcatheter placement into the nidus, and you can see that these are the dysmorphic vessels and these are the venules which are exiting from this compartment of the nidus and going to the AVM vein. Generally, the AVM veins are single and rarely they ramify. So usually, the AVM vein is a single vein which eventually ramifies into multiple veins, so which may be so-called multiple vein venous drainage or single venous drainage, depending on the situation. It would be good if you have injection of the glue or embolic agent into the nidus and losing some little bit into the proximal part of these venules without entering into the main vein of the AVM in the beginning. Because if you enter the glue into the vein, it often gives rise to a buildup of the pressure in the nidus and jeopardizes the outlet and intraoperative rupture, which is sometimes commonly seen if you inject some of the agents from the single feeder and transgress them through the intercompartmental communication, and you reach to the veins before actually embolizing the whole of the AVM nidus. Now, the concept of what you call the sulcal AVM and the gyral AVM is very important, and I think it's very handy and in defining the safe strategy for the embolization. You can see here that this is the AVM located in the watershed area of the MCA and the ACA. And when you do a microcatheterization, what you can see here is that though it is primarily supplied from the middle cerebral cortical branches, but it is being into the watershed area, it has a sump effect and pulls the blood, additional supply from the ACA. So when you do a microcatheterization, the analysis is very important because if you inject from this point, though the catheter position appears to be a nidal position, but you do inject with a little bit more pressure, you can see that the cortical branch of the anterior cerebral artery is retrogradely filling over here, which can be not filling otherwise when you are injecting the contrast with a low pressure, because it will go to the AV shunt and will not go to the normal territory of the artery. So if you inject from this point, you will have what you call polymerization of the agent into the nidus and then the reflux into the cortical vein and the source for morbidity to the patient. So once you have an intranidal deposition like this, selectively, you can eliminate these AVM completely. So what are the embolization for the definitive cure, which can be seen in the best of the circumstances, use of various agents that are available today. I think the best results which we can achieve today is about 40% by any methods. The important thing is that if you have a direct or a dominant feeding artery, monocompartmental nidus, and a dominant fistulous compartment into the nidus, then it is right from the beginning, your goal should be the therapeutic complete elimination of these AVMs. Look at this example in a young boy who presented with a Rolandic area hemorrhage and a mild hemiparesis, which was of 3/5 power. And on arteriography, we found that there was a small AVM at the Rolandic artery. It's a compact nidus, monocompartmental feeder, single draining vein. Simple. Microcatheterization, placement of the position into the nidus, and create a cast exactly like what the nidus looks like without reflux into artery, so as to prevent the morbidity in this particular so-called eloquent area of the brain that we can call it, and the elimination of the AVM completely from the circulation. You may have a multi-compartmental AVM like this, where you have to go from compartment to compartment, intranidal deposition of the glue, and create the cast exactly confronting with the nidus over here. And this is we call the footprint. You must always see the plain X-ray of these to look at the deposition of the glue as a footprint, what you have done, whether there is an arterial reflux there or not. So once you are intranidal, you eliminate, not only eliminate the AVM from the circulation, but you prevent the morbidity, and sometimes you prevent the rupture if you do not early do penetration into the venous side. So this is a long-term follow-up in this patient, and this patient is doing quite well. Another example, a deep location of AVM, monopedicular, supplied from the lenticular striate artery. And I think I do see many of my eminent colleagues here who are doing this excellent work in neurointervention. You would agree that taking our relatively rigid microcatheter, which are flow-guided microcatheter, is a difficult task into these curvatures of the lenticular striate artery. But because we use NBCA, so the use of the elite microcatheter or the magic microcatheter is relatively much easier and much safer in these situations. Once you reach to the nidal position, single what you call catheter glue injection into the nidus eliminates the AVM completely from the circulation. Venous ectasia is a source of the bleed. And whenever we are dealing with these situations like AVM, with this situation with a venous stenosis or venous ectasia like this over here, that remains a goal for the early elimination or therapeutic elimination during AVM embolization. So if you land up with a partial embolization in these cases and venous ectasia is not taken care, the risk of the rebleeding remains more or less same. So the goal remains, like in this situation, though it was a fistulous form of AVM, you can actually cross your microcatheter to the venous side. So you have to pull back rather in these situations the catheter a little bit backward, because it will have a rapid migration of the glue and you may jeopardize the venous, what you call circulation before actually blocking the shunt, which is quite high flow in this case. And precise deposition of the glue confronting with the nidus and some flow into the vein in the distal part over here is acceptable, particularly in a completely embolized AVM. So another important objective is to preoperative resection. What is the goal remains in these cases? That to reduce the size of the nidus, occlude the deep arterial feeders particularly, which are difficult for the surgeon to access onto, and if there are intranidal aneurysms of high risk or fistulous part, that should be taken care. Look at this boy with an example of presenting to us with a sudden onset headache and unconsciousness, large parietal hemorrhage, intraventricular bleed, mass effect. So middle of the night, they wanted to undergo surgery. So surgeon called us up to do an angiogram, so as to find out whether there is any cause for the bleed, and we find that yes, there is a micro AVM with a small, what you call, pseudoaneurysms in the nidus over here, And this is the source of the bleeding. So we did a preoperative embolization, and then the surgeon went under a craniotomy and the evacuation of hematoma, and the patient was saved. Embolization is a precursor of radiosurgery. The goal remains, because if you have a large AVM, it has been observed that size which is more than 3 centimeter and less than what you call volume, which is more than 3 centimeter cube, dramatically reduces the success rate of gamma knife treatment. Because in the best of the circumstances, with the 3 centimeter diameter or less, the success rate at 2 years is about 80%, and it goes exponentially low if the size goes higher. So in this situation, what we can do in a location like this, where you understand that this patient has an unruptured AVM but symptomatic with an uncontrolled seizure, you preemptively you assess that you may not be able to embolize this AVM completely from in a one session. So we decided that we'll do a partial targeted embolization in this case, reduce the size and subject this AVM to gamma knife treatment. So here the goal remains that go through all these perforating vessels, which are lenticular striate vessels in this case, which are dysmorphic, and you can see that dysplastic vessels, and they have a lot of aneurysms in the internodal portion. And you can do a size reduction, so you confine your target to the most posterior and the medial part, and lateral and the superior part can be subjected to the gamma knife treatment, which will be more what you call effective. Now, I would like to mention over here that the use of the NBCA is superior in this situation with the gamma knife treatment, because onyx relatively or other tantalum-based embolic agents interferes with the gamma knife treatment and are generally not recommended for the use. So this is study from my friend in Ajay in Pittsburgh reveals clearly that if you have a group 1 where you have a volume of the AVM which is 3 cc, the success rate goes to almost 87%. The moment it becomes 3 to 10%, the success rate of gamma knife goes to 64%. And the volume, if it is more than 10 cc, practically it is 1/4 the chance that it would be successful. So in spite of intensive advancement that we have today of different modalities, we cannot deal with this AVM situation with the use of the single modality as of now. So sometimes an intelligent combination of the two tools is very helpful in achieving a desired goal in a given patient. So AVM should not be looked in the similar way that removing them from the angiographic picture or the MR picture. It has a clinical implication. And let us look at this example. Embolization is a palliative method for the progressive disabling symptoms of the patients. This is a patient, a young middle-aged man, 45, 48 years, came with subarachnoid hemorrhage. The bleeding is in the internal carotid cistern here. So we anticipate that there is a aneurysm which is located on the A1 segment, which is supplying to the asymptomatic large AVM in the ACA territory over here, which is more of what you call, some may call it as a proliferative angiopathic kind of a picture. So here it is very clear that this is a flow-related aneurysm. They usually do not rupture, but this is a ruptured aneurysm with a nipple over here. So we did a coiling in this patient, and the patient was discharged, and 2 or 3 years later, this patient comes back to us with a symptom. He works in a transport company, so he started having his visual memory impairment. So he often make a visual spatial errors. He often forgets where the particular material or goods have to be sent. So he had a big problem in his vocational abilities. Now it is because of the fact that the AVM was located onto the medial parietal region. It was causing a sump effect from the posterior cerebral artery, and the visual association cortex was getting affected. So as a result, he was getting effect onto the visual memory symptoms. So here we decided that this AVM cannot be done in a single session as a complete embolization. So that's not the goal at all in this case. So our goal was that primarily target the area of the visual association cortex in this particular individual. So we decided to do all our embolization in the posterior compartment, And this is the deposition of the glue, and this is the final cast here and the final picture. So we removed the sump effect from the posterior part of the AVM, which is associating with the visual association cortex. And this worked quite well for the patient, and he has, until now, he's asymptomatic for those, he's back to work. So sometimes you can do a partial targeted embolization because this is not the AVM which will have imposes a high risk of the rupture. It's more of a plexiform AVM. So it is possible that we can do a targeted embolization to eliminate or to give a clinical benefit to the patient. Look at this situation. A wife of one of my colleagues who is a pharmacologist, she developed a progressive spastic quadriparesis, and it was more spasticity than the weakness actually. And on MR we found that there is a brainstem AVM over here, which is a high flow AVM, and causing lots of what you call sump effect and ischemic symptoms because of the sump effect over here. So to deal with this situation, we decided that we'll do a targeted embolization, we'll reduce the flow. But when you analyze these AVM, so this is the angiographic analysis. It has supply from the pica and the anterior sublunar artery. We did a microcatheter. On microcatheter, you find that there is a large venous ectasia over here in the draining vein, which you don't see on a global injection sometimes, right? So the moment you do microcatheterization, now you take your catheter right into the nidus and you embolize this. So by very careful and meticulous selection of the nidal injection, we could eliminate this AVM completely from the circulation, in fact. Though our goal was palliative to reduce the shunt, and we preserved the anterior spinal axis. You can see that this is the anterior spinal axis originating from the vertebral artery, and this is from the C2 segment. This is the lateral view. And patient has a remarkable improvement. She has a complete recovery in the spasticity and back to normal activity. So the treatment objective is associated with sometimes if you have the weak part of the angioarchitecture like this, venous ectasia, as I said, particularly in a high flow AVM, your goal is to deal with these AVM along with the shunt and the filling of these what you call ectasia. And in the bargain, we actually landed with a complete embolization of this AVM. It's rarely been performed also as a result of the following the AVM surgery performed by our neurosurgical colleague. So when you do a check angiography after the surgery, like in this patient, a young boy, intracerebral hemorrhage and marked ventriculomegaly. So he underwent surgery and shunt placement. And when we did the angiogram, we found there was a small shunt was still persistent. So it was a simple job. It's a daycare procedure. You take your microcatheter up, embolize this AVM, and the patient was relieved next day. This is the follow-up. Another case example with a intracerebral hemorrhage. But here you see on a global injection, sometimes you can miss this small shunt over here, but you do a magnification, you find that this is a radicular corticomedullary artery going deep into this ectatic area of the AVM and connecting to the vein of Galen over here through the internal cerebral vein. So we went over microcatheter here, and again, this was a post-surgical case, and we eliminated this shunt, which actually poses a larger threat of rebleed because this is subependymal vein and a ectatic, what you call shunt area on the venous side here. Post-reduced surgery is another situation where you will end up with no choice but to embolize these patients. Look at this example, young girl, 3 or 4 episodes of subarachnoid hemorrhage, which are all intraventricular, third ventricular bleed. She underwent 2 sessions of gamma knife surgery in 4 years' time. And then she was continued to have what you call recurrent hemorrhages, but only presenting with headaches, no neurological deficits. Look at this AVM on angiogram, very high flow. These are the AVM which are refractory to the radiosurgery. They have a lot of arteriopathic changes, flow-related aneurysm here, even into the ophthalmic artery region over here, and a leptomeningeal collateral circulation from this. Went with the microcatheter, we blocked the shunts and eliminated this AVM completely from the circulation. You can see the cast of the glue, which confronts to the deposition into the venous channels and the shunt area over here without jeopardizing the arterial pedicle, which is actually now dilated at the moment, but gradually it will regress and would be, patient had a good recovery and she's doing fine so far. Results of AVM embolization, I had an opportunity to work with Professor Valavanis in late 90s, and that's where I learned the concept and the technique of endovascular embolization of this AVM. So this is an old publication, old data from Professor Valavanis' series. The complete obliteration rate in his hand, which I consider is one of the best results that we have today in the global literature, is about 40%. And subtotal occlusion was seen in about 19 patients. So it is important to observe here that when you do a partial embolization, what you call in some of the cases, you can still achieve a complete cure in about 60% or 65% of the cases. So even targeted or subtotal occlusion of the AVM in some situation eventually leads to the complete elimination of the AVM from the circulation. These are our results from 1999 to 2012, 203 cases that we had. Complete obliteration rate is 32%. Subtotal occlusion we had was in 40 cases, which constitutes about 20%. Partial embolization which was classified as 50 to 90% obliteration of the AVM, but eventually we landed with about 60% complete cure of the AVM in these group of patients. We had 3% mortality which were linked to either intraoperative or post-operative. 2 of them were post-operative bleed, which was almost within 12 hours. And in spite of the decompressive craniotomy and other methods of critical care management, the patient succumbed to the procedural complication, I would call it. 1.5%, morbidity 3.5% we had, but the major disability was seen in about 3% cases only. So the brain AVM, the principles and the embolization of the AVM, the concept remains that it's a complex clinical situation. We need to understand it from different point of view, not only from the imaging point of view. Appropriate case selection is very important to keep the risk of the intervention low and the success rate of the treatment for the patient. Even sometimes keeping some part of the AVM into the circulation, but the patient is asymptomatic, remains the clinical goal of AVM management. Definition of goal should be identified and targeted prior to the procedure. This is what we consider as one of the most important goal of the AVM management. Ideal picture on angiography is not always a requirement in the treatment of brain AVM. Thank you very much for your kind attention.
Thank you, Dr. Shakir. Are there any questions? Okay. Thank you, doctor.